Today, we are undertaking an in-depth exploration of a category of drugs that manages the fundamental balance of life, fluid. We're cracking open the pharmacologic playbook on diuretics. You might have heard them referred to simply as, water pills. But the source material, a dense chapter from a core medical text, shows they are anything but simple. They are highly sophisticated tools, each designed to precisely target different cellular pumps within the kidney.
That distinction is absolutely critical. I mean, if we are to understand their power, we need to first properly define them. Diuretics are technically natriuretics.
Natriuretics. Okay, let's break that down.
It means they're drugs that fundamentally cause a net loss of sodium Na++ seal and consequently water in the urine. By ejecting that sodium, their core mission is achieved, reducing the extracellular fluid volume. This reduction in volume is the essential mechanism behind their universal prescription in managing major conditions like hypertension, congestive heart failure, and edema.
And that is our deep dive mission. Moving past the simple label to grasp the architectural complexity. We're going to categorize these agents, which vary wildly in strength based on where they strike in the kidney. We'll dissect the molecular mechanism of how they work at a cellular level, and we will spend necessary time reviewing the crucial side effects and the specific clinical scenarios where each of the 5 classes excels. For the next 40 minutes or so, the kidney, that amazing complex filter, is the central map we'll be navigating. It's always helpful to start with history because the evolution of diuretics is a great example of how clinical need drives pharmaceutical innovation. The modern oral drugs we know today are ubiquitous, but managing fluid overload wasn't always so straightforward. What were physicians relying on before, say, the 1950s?
Well, you have to frame the historical context around the desperation to manage severe fluid retention. Before modern pharmacology, the earliest substances that had any reliable diuretic action date back to the 1920s. These were crude agents like calomel and the organomercurials.
Organomercurials, so mercury-based drugs. That's right.
Oh, highly problematic. They had to be administered via injection, and they dominated the field for almost 40 years. That longevity tells you how critical the medical need was. They were effective enough to endure despite the huge inconvenience and toxicity.
And often, discovery comes from unexpected places. I recall from the source material that early research on entirely different drug classes inadvertently pointed toward the mechanism of diuresis.
Yes, the early days were full of surprising cross-pollination. For instance, research into the sulfur-containing antibiotic known as sulfonamides showed an unexpected side effect.
Which was?
Acidosis and mild diuresis. This unintended consequence highlighted a key enzyme, carbonic anhydrase, and that led directly to the development of the carbonic anhydrase inhibitors. We still use those today, though mainly for specialized non-diuretic reasons, which we'll get into.
But the real game changer was the ability to administer the drug orally. That must have shifted the management of chronic diseases like hypertension out of the clinic and into the patient's daily routine.
That truly was the revolution. The major breakthrough arrived in the 1950s, when those early experiments with the sulfonamides led to the chemical synthesis of the first modern orally active diuretic, chlorothiazide.
A monumental leap.
Absolutely. It offered patients a manageable, accessible way to regulate fluid balance chronically. This success then led rapidly to the development of the next critical class in the 1960s, the high ceiling, or loop, diuretics, agents like furosemide and ethacrynic acid.
So chlorothiazide established the chronic oral baseline, while the loops provided the necessary heavy artillery for acute severe edema. It sounds like the entire paradigm shifted within a single decade.
It did. And while scientists were perfecting potency, they were simultaneously addressing the biggest liability of these new, powerful agents.
Potassium wasting.
Exactly. The sources highlight the parallel development of aldosterone antagonists, specifically spironolactone, and the non-steroidal K+ sparing diuretics like triamterene and amiloride.
That parallel development is insightful, isn't it? It signifies that almost from the beginning of the modern diuretic era, there was an immediate recognition that fluid management couldn't be done safely without active potassium management.
Precisely. The side effect was so integral to the mechanism that the counter tool had to be developed simultaneously.
It's fascinating.
And the widespread clinical application of this entire toolbox, especially for hypertension, has profoundly impacted clinical practice. And as we mentioned earlier, these specific chemical probes have, in turn, enhanced our understanding of fundamental renal physiology itself.
By creating a drug that specifically blocks one pump in one spot, We could reverse engineer the kidney's normal function and map out the entire complex system of transport.
That's it, exactly.
Okay, let's look at the organizational chart provided in the sources. To really master this topic, we need to understand the 5 core classifications. What is the organizing principle here?
The organizing principle is dual. Maximal efficacy and site of action within the nephron. If you know where the drug works, you know how powerful it can be and what its specific side effects will be. So we divide them into 5 main categories. First, the high-ceiling loop diuretics. These are the most powerful. They work high up in the nephron, blocking the NOT plus Nash's 2Cl cotransport system.
Examples being furosemide, bumetanide.
And torsemide, yes. They are capable of blocking up to 25% of filtered sodium reabsorption, a huge amount.
25%. Yeah.
Second, the medium efficacy diuretics, which are the thiazides and the thiazide-like compounds. These act further down the tubule, inhibiting the NOT plus diacetyl symport. This category includes drugs like hydrochlorothiazide, chlorthalidone, and metolazone. They block about 8% of filtered sodium reabsorption.
Okay, so a significant drop in power from 25% to 8%.
A big drop.
So the first 2 are the workhorses. The remaining 3 categories are generally classified as weak or adjunctive diuretics.
That's right. Category 3 is the carbonic anhydrase inhibitors, CASE, represented by acetazolamide. These drugs work high up in the proximal tubule, but are considered weak natriuretics because their action is limited by the resultant metabolic acidosis.
We'll circle back to that.
Category 4 is the osmotic diuretics, which are non-electrolyte solutes like mannitol. These exert their effect purely through physics by increasing the osmotic load of the filtrate to pull water into the urine.
So no receptors, no channels, just pure osmosis.
Exactly. And finally, category 5, the potassium-sparing diuretics. These are critical adjunctive agents. They include the steroidal aldosterone antagonists like spironolactone and eplerenone, and the nonsteroidal renal epithelial Na plus channel inhibitors like amiloride and triamterene. Their job is less about massive diuresis and more about electrolyte management at the very end of the nephron.
This clear 5-part classification provides the roadmap for our deep dive into the mechanisms. Let's start with the undisputed heavyweights. The high-ceiling diuretics. Agents like furosemide can produce up to 10 liters of urine a day. That is a level of efficacy that completely transforms the clinical management of a patient in fluid overload.
The key to their unparalleled power is their strategic site of action. The thick ascending limb of the loop of Henle.
The TL.
The TL. This segment is often called the kidney's primary salt reabsorption engine because it normally handles and successfully reabsorbs approximately 25% of the total filtered sodium load.
So if a drug can effectively block reabsorption at that crucial bottleneck, the resulting fluid loss downstream is massive, regardless of what the later, less powerful segments of the nephron try to do.
Exactly. The molecular mechanism involves inhibiting the Na plus Met K plus NECA2Cl cotransporter, often abbreviated as NKCC2.
And where is that located?
It resides on the luminal membrane, the side facing the tubular fluid of the tail cells. This cotransporter is a complex glycoprotein with 12 membrane-spanning domains. Furosemide and its relatives bind to that protein, preventing the coordinated reabsorption of 1 sodium ion, 1 potassium ion, and 2 chloride ions.
That structural detail, 12 membrane-spanning domains, really highlights that this isn't a simple pore, but an incredibly complex, high-capacity machine. By inhibiting it, you not only flush sodium and chloride, but also potassium. What's fascinating is how this action completely disrupts the electrical environment of the tubule.
That's the subtlety that elevates this discussion beyond basic water loss. Inhibition of the NKCC2 means massive amounts of Na plus Cl and K plus rush downstream. But importantly, the normal action of the NKCC2 creates a necessary electrical gradient. It's known as the lumen-positive transepithelial potential difference within the talo.
Okay, let's unpack that highly technical phrase for the listener. A lumen-positive charge normally means the inside of the tubule is slightly more positive than the surrounding tissue. Why is that charge important?
That electrical gradient acts as the driving force. That positive charge is what passively pushes other positively charged ions, specifically calcium, Ca2+, and magnesium, Mg2+, out of the tubular fluid and back into the body.
Ah, so it's like an electrical nudge.
Precisely. By abolishing that positive charge, by electrically shutting down that system, the loop diuretics prevent the reabsorption of Ca2+ and Mg2+A. They are washed away.
And that's why they're known as K2+ embolsing diuretics.
It's a critical distinction, yes.
This mechanism explains why they are high ceiling. The efficacy curve keeps climbing with dose until toxicity limits are hit. And you mentioned a key clinical differentiator, These drugs work even when the kidney is failing.
Yes. The source specifies that they retain efficacy in patients with severely impaired renal function, where other diuretics often fail because they rely on higher sodium loads reaching distal segments. Loops bypass this problem by acting so early and powerfully. This makes them the drug of choice in chronic renal failure and, crucially, in acute pulmonary edema.
The speed of furosemide is legendary, particularly in emergency situations. What does the pharmacology tell us about the onset and duration of its action?
When rapid response is needed, furosemide is delivered intravenously, 4V, and the onset of diuresis is almost immediate. We're talking 2 to 5 minutes.
That is incredibly fast.
It is. If given orally, onset is slower, usually 20 to 40 minutes. However, the duration is relatively short, often 3 to 6 hours, which means the potent effect is also transient.
Let's follow the drug's physical journey through the body. Furosemide enters the bloodstream, but it doesn't just filter out via the glomerulus and slide down the tube to the TL, does it?
It doesn't, and this is a critical pharmacokinetic detail. Furosemide is highly protein-bound in the plasma, meaning only a small fraction is filtered. To reach its site of action on the luminal side of the towel, it must be actively secreted into the tubular fluid in the proximal tubule.
Secreted, so it's pushed out of the blood.
Yes, via the organic anion transport system.
That means the drug has to fight for transport space to reach its target. We need to flag that transport system now because it comes back later as a critical drug interaction point. The fact that the drug needs to be actively transported out of the blood just to get back into the tubule is an essential detail.
It connects directly to drug efficacy. If that transport system is blocked or saturated, the drug cannot get to the NKCC2 cotransporter, and the patient becomes diuretic resistant.
Now let's unpack that extraordinary hemodynamic effect that gives furosemide its emergency superpower. The rapid relief it provides in acute pulmonary edema, often before the diuretic effect is even kicked in.
This effect is initially independent of the kidney. Furosemide causes acute systemic venodilation. It relaxes the large veins.
And how does it do that?
This effect is mediated by the release of prostaglandins, or PGs. When the veins relax, the vascular capacitance increases, which immediately lowers the amount of blood returning to the heart, specifically reducing the left ventricular filling pressure.
So if a patient is drowning in their own fluid because their left ventricle is failing, this rapid venodilation gives the care team minutes, literal minutes, to stabilize them. It eases the pressure on the failing heart before the patient has produced any significant urine volume.
Precisely. It's a two-stage attack. First, the rapid PG-mediated relief of pressure on the circulatory system, and second, the slower, highly potent diuresis that removes the excess fluid volume over the next few hours. Additionally, furosemide causes a transient increase in overall renal blood flow, redistributing it, which is an ancillary benefit.
Furosemide is the classic, but let's compare it to its two modern rivals, bumetanide and torsemide. How do these drugs differentiate themselves, particularly in challenging clinical settings?
Furosemide is the prototype, and its dosing is quite flexible, ranging from 20-80 milligrams daily, but capable of going up to 600 milligrams daily in patients with severe renal failure. Bumetanide is the first major variant. It is approximately 40 times more potent than furosemide on a milligram-per-milligram basis.
40 times.
But its main advantage lies in its absorption profile. Bumetanide is highly lipophilic and has much better and more consistent oral absorption. We're talking 80% to 100% bioavailability, compared to furosemide, which is only about 60% absorbed orally.
Better absorption means more predictable results. I imagine that would be crucial for a patient with chronic congestive heart failure who may have GI edema, which would severely compromise the absorption of less lipophilic drugs.
That's spot on. GI edema interferes significantly with the uptake of furosemide. Because bumetanide's absorption is so reliable, it is often preferred for chronic CHF patients where GI congestion is a known issue. It's also sometimes used in patients with furosemide allergy, although cross-allergy can still occur given their chemical relation to sulfonamides.
And what clinical advantage does torsemide offer?
Torsemide is 2-3 times more potent than furosemide, similar to the others in high efficacy. Its differentiating feature is its longer duration of action, spanning 4 to 8 hours. This slightly extended half-life allows for less frequent dosing and may offer smoother volume control throughout the day, which can improve patient compliance. It's used up to 100 milligrams twice daily in patients dealing with resistant edema or renal failure.
Moving from the raw power of the loops, we turn to the medium efficacy class, the thiazides and the relative. They may not pull 10 liters of water in a day, but they are arguably the most universally prescribed class of diuretics, holding a cornerstone position in chronic disease management, particularly hypertension.
This class includes hydrochlorothiazide, chlorthalidone, bentolazone, and others like indapamide. Their primary site action is the early distal convoluted tubule, the DT.
So this is significantly further down the nephron than the TL.
Yes, much further down.
What is their target at this stage of the filtration process?
Their molecular target is the Na plus Nax Cl symporter, often called NCC. Similar to the loop target, this is a large glycoprotein with 12 membrane-spanning domains located on the luminal membrane. Thiazides inhibit this symporter, blocking the coupled reabsorption of sodium and chloride back into the body.
Because they are acting on a segment that receives substantially less salt, since the loops and the proximal tubule have already done most of the work, their efficacy is naturally lower.
Precisely. They only reduce the reabsorption of about 8% of the filtered sodium load compared to the 25% handled by the loops. This limitation in efficacy is compensated by their long duration of action, making them ideal for chronic management.
Now, you mentioned the flat dose response curve specific to thiazides. Why is that important for the physician to understand?
It means that the ceiling of their natriuretic effect is hit very quickly. If you increase the dose of hydrochlorothiazide beyond, say, 100 milligrams, you might increase the incidence of adverse effects, like potassium loss or metabolic issues, but you gain little to no additional diuresis.
So more drug doesn't mean more effect.
Exactly. The therapeutic benefit plateaus quickly. This contrasts sharply with loops, where increasing the dose still yields more urine output. For thiazides, if you need more effect, you look to combination therapy, not simply a higher dose.
All these compounds are well absorbed orally, which is key for chronic first-line use. But the variability in half-life is huge, dictating clinical choice.
Indeed, hydrochlorothiazide offers a typical half-life of 6–12 hours. However, chlorthalidone has a remarkably long half-life, stretching 40 to 50 hours.
That's a huge difference.
It is. Indapamide is also long-acting and highly lipophilic. These longer durations allow for sustained once-daily dosing, which correlates strongly with better patient adherence and more consistent blood pressure control.
Their primary application is, of course, hypertension. Let's break down the two components of that blood pressure lowering effect.
Initially, the diuresis reduces total blood volume, leading to a quick drop in pressure. However, what sustains their antihypertensive action long-term, even after the fluid volume stabilizes, is a generalized reduction in peripheral vascular resistance.
So it actually relaxes the arteries over time.
Yes, the mechanisms for this vascular effect are complex, possibly involving reduced sodium content in the vascular walls, making the arteries less stiff. This long-term vascular effect is why they are cornerstones in hypertension management.
Here is the truly fascinating distinction, the clinical aha moment that sets thiazides completely apart from loops, their effect on calcium homeostasis.
This is a vital difference and a major clinical advantage. Loops waste calcium, but thiazides decrease renal C2 plus excretion.
So they're calcium sparing.
They promote the reabsorption of calcium, essentially making them calcium-sparing drugs. This mechanism is partly linked to volume contraction, which enhances calcium reabsorption in the proximal tubule, and possibly through direct activation of calcium channels in the distal tubule.
This unique property means a physician managing two chronic diseases in an elderly patient, say hypertension and osteoporosis, might automatically lean toward a thiazide, effectively treating two problems with one drug.
Absolutely. The clinical utility is profound. Thiazides are used specifically to treat hypercalciuria, excessive calcium in the urine, which is a common cause of recurrent calcium oxalate kidney stone formation. They can prevent the formation and recurrence of these debilitating stones.
Let's discuss metolazone. The sources highlight its use in treating diuretic resistance, even when the patient has advanced renal failure. Why is it the outlier in this class?
Metolazone is unique because it retains its efficacy when the patient's glomerular filtration rate, or GFR, drops very low, even below 15 milliminon, where standard hydrochlorothiazide is often useless.
And it's used in something called sequential nephron blockade.
Yes. It is the key ingredient in overcoming diuretic resistance via that strategy.
Why does the resistance happen in the first place? And how does blocking two segments sequentially overcome it?
Long-term, high-dose use of loop diuretics, while effective initially, causes the distal convoluted tubule, the DT, to physiologically adapt. The DT cells undergo compensatory hypertrophy.
Meaning they literally get bigger and stronger.
Yes, they increase their size and their capacity to reabsorb sodium. The kidney is simply too good at finding a workaround. So the loop diuretic blocks the main floodgate in the tau, but the small gates downstream in the DT get larger and more efficient, mitigating the effect.
So you're plugging one leak and another one springs open.
That's a good way to put it. Sequential nephron blockade, combining the loop diuretic with metolazone, simultaneously blocks both reabsorption sites, effectively shutting down the kidney's compensatory mechanism and achieving a dramatic restoration of diuresis.
That's a perfect example of how clinical practice uses deep molecular insight to overcome physiological roadblocks. And finally, let's touch on chlorthalidone and indapamide again, which are often the preferred thiazide-like agents in major cardiovascular guidelines.
They are favored because their prolonged half-lives provide sustained 24-hour blood pressure control. Furthermore, major clinical trials often included these specific agents, demonstrating long-term cardiovascular outcome benefits, such as reducing strokes and heart attacks, that sometimes slightly exceed the data available for standard hydrochlorothiazide. Their effectiveness and superior duration make them the default choice for first-line antihypertensive therapy in many protocols.
We now have a clear distinction between our two main tools: the potent, fast-acting CI2 plus wasting loop and the medium-efficacy, long-acting CI2 plus sparing thiazide. How do these differences translate into specific clinical decisions?
The choice is defined by the patient's immediate need and underlying pathology. For edema management, high-ceiling loops are essential for urgency. They are preferred for the rapid mobilization of severe, life-threatening edema, whether it stems from cardiac, hepatic, or renal failure. They are the only choice for acute pulmonary edema.
And the thiazides for edema?
Thiazides are used for managing mild to moderate edema or for long-term maintenance after the initial fluid has been cleared by a loop diuretic. They are ineffective in advanced renal or hepatic edema due to their lower efficacy ceiling.
And for hypertension?
Thiazides are the standard first-line agent for essential hypertension due to their sustained effect on peripheral vascular resistance and proven safety profile over decades.
And the loops?
High-ceiling diuretics are reserved for hypertension only when there are complicating factors. If the patient has coexisting renal insufficiency, if they have severe heart failure, or in cases of truly resistant hypertension.
And wrapping up the specialized uses?
Beyond fluid management, we use thiazides for nephrogenic diabetes insipidus, where the mechanism is counterintuitive. They cause mild volume depletion, which tricks the kidney into reducing the amount of free water it produces, thereby significantly reducing polyuria.
Less water in means less water out. Fascinating.
And, of course, hypercalciuria, using their calcium-sparing effect to prevent recurrent kidney stones.
We've established that the two biggest workhorses, loops and thiazides, share a critical liability. They waste potassium. This brings us to the third pillar of classification: the potassium-sparing agents, which are absolutely crucial in minimizing cardiac risk.
This is a safety class. Hypokalemia, or K+ depletion, is the most common and dangerous metabolic side effect of K+ wasting diuretics. If K+ levels fall below 3.5 millieql, the patient is at risk for muscle weakness, cramps, and most importantly, dangerous arrhythmias.
And this risk is amplified when other drugs are on board, right?
Exponentially increased if the patient is simultaneously taking a cardiac glycoside like digoxin, as hypokalemia enhances digoxin toxicity. Therefore, K+ sparing drugs are nearly always used adjunctively with loops or thiazides to maintain potassium stability.
Let's start with the steroidal class, the aldosterone antagonists, and their indirect method of saving potassium.
The agents here are spironolactone and eplerenone. They work in the late distal tubule and the collecting ducts. They are steroids that block the mineralocorticoid receptor, or imorildosterone, a hormone released during volume depletion, normally activates this receptor. This activation promotes sodium reabsorption in exchange for the secretion of potassium and hydrogen ions.
So they're blocking the hormones receptor.
By blocking the MR, these antagonists halt the gene transcription process that increases those channels and pumps, leading to decreased Na+ reabsorption and, crucially, decreased K+ and H+ secretion.
That reliance on gene transcription explains a key pharmacokinetic detail, doesn't it? The slow onset.
Yes. Spironolactone, the prototype, is notorious for its slow onset of action. It takes 1 to 2 days to exert its full effect because it must wait for the turnover of the ion channel proteins whose production it is inhibiting. This makes it unsuitable for acute management, but perfect for chronic conditions.
The sources are very clear that spironolactone comes with significant adverse effects directly related to its chemical structure as a steroid.
Since spironolactone is non-selective, it binds not only to the mineralocorticoid receptor, but also to androgen and progesterone receptors.
And that leads to.
For men, this non-selectivity commonly leads to side effects like gynecomastia, breast tenderness, and impotence. For women, it can cause menstrual irregularities. These hormonal side effects often lead to poor adherence, despite the drug's significant benefits.
So eplerenone was developed to solve this compliance and side effect issue by achieving greater selectivity.
Eplerenone is a major pharmaceutical advancement. It is a highly selective aldosterone antagonist exhibiting far less affinity for the androgen and progesterone receptors. This improved selectivity translates directly into much better tolerance and far fewer hormonal side effects. It's specifically indicated for chronic heart failure management and post-myocardial infarction patients with left ventricular dysfunction, where tolerance is paramount for long-term survival.
Now let's turn to the other half of the K plus daring class. The nonsteroidal agents, amiloride and triamterene. They get the same result, conserving potassium, but they achieve it through a direct, immediate physical block.
That's the key difference.
Yeah.
They work independently of aldosterone. Amiloride and triamterene directly block the luminal NET plus channels, often referred to as ENAC, in the late distal tubule and collecting duct cells.
And if they block the ENAC sodium channel, how does that translate into potassium conservation?
It's an electrical effect. When sodium normally enters the cell through ENAC, it creates an electrical charge imbalance. The tubular lumen becomes electrically negative relative to the blood.
Okay.
This negative electrical potential is the essential driving force that pulls K plus and H plus out of the cell and into the urine. By blocking NAT plus entry, amiloride and triamterene reduce the negative charge in the lumen. Without that strong negative potential, the secretion of K plus and H plus is inhibited.
So they turn down the electrical magnet, pulling the potassium out.
That's a perfect way to describe it. They conserve both potassium and hydrogen ions, while only providing a weak diuretic effect because this segment handles so little salt.
They are definitely adjunctive tools then, used primarily for protection. What is the biggest danger profile?
Their main adverse effect is the exact opposite of the drugs they counteract: the risk of hyperkalemia or dangerously high potassium levels.
And that risk is higher in certain patients.
Yes, particularly acute in two scenarios. First, if the patient has any degree of underlying renal insufficiency, which impairs the kidney's ability to excrete K plus SAN. And second, if they are used concurrently with other drugs that already raise K plus levels, such as ACE inhibitors, ARBs, or NSAIDs.
We move now to the specialized or niche agents. These drugs are technically diuretics, but their most common clinical uses are often entirely non-diuretic. Let's look first at the carbonic anhydrase, or CASE inhibitors, like acetazolamide.
Acetazolamide reversibly inhibits the enzyme carbonic anhydrase, specifically the type 2 isoform found in the proximal tubule. This enzyme is crucial for the kidney's ability to reclaim filtered bicarbonate. It does this by generating hydrogen ions, H plus ABRAC, which are then exchanged for luminal sodium.
So if you inhibit carbolin, you lose the H plus needed for that exchange, which leads to massive excretion of bicarbonate.
Exactly. The primary pharmacological effect is a dramatic forced excretion of HCO3. This massive bicarbonate loss is why it's a diuretic, but it's also why it's a self-limiting diuretic.
How so?
The loss of HCO3 causes systemic metabolic acidosis. This acidosis then inherently reduces the drug's own effectiveness over time. Because of this, it only affects about 5% of the filtered sodium load.
Given its weakness as a diuretic, its primary role in modern medicine must lie in those niche areas.
It does. The most widespread use is for glaucoma. CASE is also found in the ciliary body of the eye, where it is responsible for producing the aqueous humor. By inhibiting CASE there, acetazolamide lowers the production of aqueous humor, thereby lowering intraocular pressure.
And the mountain sickness connection? That's always seemed so random.
It's used for mountain sickness prophylaxis, typically 1 to 2 days before rapid ascent to high altitude. It works by inducing metabolic acidosis, which stimulates respiration and helps the body acclimate to the lower partial pressure of oxygen. This prevents symptoms like severe headache, nausea, and high-altitude cerebral or pulmonary edema.
So it forces your body to breathe more, essentially.
In a way, yes. And finally, it can be used for alkalinizing urine. By causing HCO3 excretion, it raises the urine pH, which can be useful for promoting the excretion of acidic drugs, for example.
The final class is the osmotic diuretics, with mannitol as the main drug. This is fundamentally different from every other drug we've discussed because it doesn't interact with any receptor or ion channel. It works purely on the principle of water movement.
Mannitol is a low molecular weight, non-electrolyte substance. Because it is given intravenously in large quantities, it is freely filtered by the glomerulus, but is minimally reabsorbed by the tubule. The crucial mechanism is that this massive concentration of mannitol in the tubular fluid dramatically increases the filtrate's osmolarity. This high osmotic pressure then draws water osmotically from the body and into the tubule fluid, preventing its reabsorption.
So it drags water along with it, and this process also inhibits the passive reabsorption of salt because the concentration gradients are disrupted. Since it's not absorbed orally, it has to be given IV, usually as a 20% solution, highlighting its role in acute controlled settings.
Absolutely. Its primary uses are defined by its ability to exert osmotic pressure across semi-permeable membranes. Its most famous application is reducing increased intracranial or intraocular tension. In cases of cerebral edema, severe head injury, or during neuro or ocular surgery, mannitol is administered to draw water out of the brain parenchyma or the CSF.
Lowering the pressure in a closed space.
Exactly. This rapid reduction in volume within these enclosed spaces lowers the pressure quickly and effectively.
And what about its use in acute renal failure? The sources mention using it for forced diuresis.
It can be used to maintain urine flow in high-risk patients, those in shock or trauma before established acute renal failure occurs. The goal is to produce a forced diuresis to enhance the excretion of toxins or harmful metabolites, protecting the renal tubules from potential damage.
But the very nature of mannitol pulling water from the cells into the extracellular volume presents serious risk, particularly for cardiac patients.
The contraindications are severe. Mannitol is absolutely contraindicated in patients with established severe renal failure, specifically if they are anuric, meaning unable to form urine.
Why is that?
If the kidney cannot excrete the mannitol, the drug remains in the plasma, pulling vast amounts of water from the intracellular space and massively expanding the extracellular fluid volume. This rapid expansion can lead to circulatory overload, which would severely exacerbate active heart failure or, worse, precipitate life-threatening pulmonary edema. You must confirm the patient can still pass urine before starting mannitol.
We've established that diuretics are powerful tools, but they fundamentally shift the body's electrolyte and fluid balances. It's vital to understand that their power is intrinsically linked to their risks. We need to emphasize the necessary caution required when using them.
We circle back to the central issue, hypokalemia, potassium depletion. This is the most prevalent and clinically significant side effect of both high-ceiling and thiazide diuretics. It is simply the overshooting of the mechanism. The increased sodium reaching the distal tubule drives the K plus Na plus exchange pump too aggressively, resulting in excessive potassium secretion.
And beyond the cramps and muscle weakness, the primary danger here is cardiac.
Absolutely. Hypokalemia fundamentally disrupts cardiac electrical stability, leading to muscle weakness, fatigue, and dangerous ventricular arrhythmias. And the interaction with digoxin is non-negotiable. Hypokalemia heightens the sensitivity of the cardiac muscle to digoxin, increasing the risk of life-threatening toxicity.
What about shifts in sodium concentration, hyponatremia?
Dilutional hyponatremia or low sodium is a real risk, especially with high-ceiling diuretics in severe heart failure patients. These are patients who often already restrict their salt intake, but are retaining large amounts of water. The potent diuretic action can lead to a state where the patient is volume overloaded but has a diluted sodium concentration.
So, too much water, not enough salt.
Exactly. And paradoxically, the solution is often not salt tablets, but water restriction or treating the underlying heart failure.
Let's address hyperuricemia. Why do both loops and thiazides tend to raise uric acid levels, which can precipitate gout?
The mechanism differs slightly, which is interesting. Both classes can elevate uric acid. For loop diuretics, it's thought to be due to competitive inhibition with uric acid for the organic anion transport system in the proximal tubule.
The delivery truck we mentioned earlier.
The very same. The diuretic is fighting for secretion space, and the uric acid backs up into the plasma. Thiazides, conversely, tend to actively decrease the renal excretion of uric acid. Regardless of the mechanism, the resulting elevation can trigger acute gout attacks.
We also need to talk about the long-term metabolic syndrome effects associated primarily with thiazide use.
Long-term, high-dose use of thiazides has been definitively linked to unfavorable metabolic changes, specifically hyperglycemia and dyslipidemia. They can potentially worsen pre-existing diabetes or lipid abnormalities.
And finally, that specific dose-related toxicity of the loops, ototoxicity.
Hearing loss and ototoxicity are well documented, though thankfully rare, side effects of the high-ceiling diuretics. It is a dose-related risk, significantly increased when the drug is given rapidly via IV or if the patient has underlying renal insufficiency, which prolongs the drug's exposure time. The underlying mechanism is believed to be a direct toxic action on the hair cells in the internal ear.
Let's focus on the critical drug interactions that undermine efficacy. We discussed the dangerous synergy between hypokalemia and digoxin toxicity. What else significantly interferes with the action of loops and thiazides?
The two biggest classes of interference relate back directly to the molecular mechanisms we detailed earlier. First, NSAIDs, like indomethacin.
Common pain relievers.
Very common. They significantly diminish the diuretic and antihypertensive action of both loops and thiazides. NSAIDs inhibit prostaglandin synthesis in the kidney, and prostaglandins are key mediators of local renal blood flow and also mediate the rapid venodilation effect of furosemide we talked about. Inhibiting PG production can cause renal vasoconstriction and interferes with the diuretic's ability to act optimally.
So they basically work against each other.
They do. Second, the interaction involving probenecid. Probenecid competitively inhibits the tubular secretion of both thiazides and loops in the proximal tubule.
So this is that competitive fight for the organic anion transport system space we flagged earlier. Probenecid, often used for gout, is literally blocking the delivery truck that furosemide relies on to reach its target.
That's the perfect analogy. If probenecid wins the fight for that transport mechanism, the concentration of the diuretic reaching the active site is drastically reduced, neutralizing its efficacy.
Let's move to the challenge of diuretic resistance. When a patient, often with severe underlying disease, becomes refractory to the high doses of loops or thiazides, what physiological factors are at play?
Diuretic resistance arises from several complicated factors. First, impaired absorption. In severe CHF or cirrhosis, edema in the GI tract can severely impair the oral absorption of the diuretic.
So the pill never even gets into the system properly.
Right. Then there's reduced delivery from severe renal insufficiency and compensatory hyperaldosteronism, where the body fights back by producing more aldosterone to retain salt, and of course, nephron adaptation. This is the one we already dove into, the long-term use of loop diuretics causing compensatory hypertrophy of the distal convoluted tubule.
And finally, overcoming this resistance often relies on the sophisticated strategy we introduced, sequential nephron blockade.
By addressing that last point, the nephron adaptation, sequential nephron blockade becomes necessary. We combine the loop diuretic with a thiazide, usually metolazone, ensuring two major reabsorption sites are simultaneously shut down. This synergistic approach often restores a profound diuresis in even the most refractory cases, proving that the solution lies in understanding the complex architectural adaptations of the kidney. If you take only one overarching insight from this deep dive, it should be that diuretics are not a single class of simple water pills. They constitute a highly precise pharmacological toolkit with 5 distinct classifications, each targeting a different cellular pump or transport mechanism across the renal tubule. The difference in efficacy is striking. Loops handle about 25% of filtered sodium, thiazides about 8%, and the K+ sparing agents only 3% to 5%. Knowing where they act and how much salt they move defines their entire clinical utility and risk profile.
That distinction, efficacy, site of action, and electrolyte effect is absolutely paramount for any learner. So let's summarize the final key clinical takeaways. First, remember the crucial clinical difference between loops and the thiazides. Loops are rapid, high-ceiling, K+ wasting, and uniquely CO2+ by wasting. Thiazides are medium efficacy, long-acting, and crucially CO2+ sparing, making them ideal for hypertension and kidney stone prevention. Second, understand the strategic role of the potassium-sparing drugs. They are rarely used as primary diuretics for volume management. Their job is primarily defensive and adjunctive, a cardiac insurance policy against hypokalemia induced by the stronger classes. Third, remember that many of the listed side effects are simply the drug's mechanism overshooting its mark. Hypokalemia is the clearest example of the body forced into an excessive exchange of K+ for Na+ under duress. And this incredible journey through renal transport mechanisms leaves us with one provocative final thought, connecting the very beginning of the drug's action to the entire landscape of polypharmacy. We noted that highly effective drugs like furosemide and the thiazides must be actively secreted by the organic anion transport system in the proximal tubule to reach their site of action. This same highly efficient transport pathway is utilized by a vast array of other compounds, antibiotics, common toxins, and other medications like probenecid. If the body is trying to excrete a toxin or clear another essential medication via that limited shared pathway, does the diuretics competitive fight for that transport space fundamentally alter how the body handles other life-saving medications at the cellular level? And what are the long-term hidden implications of that microscopic competition on drug safety and efficacy, especially in patients with complex multi-drug regimens managing chronic disease?
That competitive environment is always something to consider. The simple water pill turns out to be a key player in a much larger cellular drama.
The complexities are endless. Thank you for joining us for this deep dive.